I think you're all good to go. We're just going live on Facebook, so give me 1 minute.
Okay.
Okay, go ahead, Nisal.
Okay, so good evening all for those in the UK, and good morning to those of you tuning in from the USA. I'm excited to be hosting this webinar on Project Violet, which focuses on pushing the boundaries of cancer treatment by utilizing venom-based therapeutics, a cutting-edge innovation in the fight against cancer. So our talk today is brought to you by BSMS OHP Society in collaboration with BSMS PaedSoc. So there were many reasons why I decided to host a talk on this innovative area of treatment against cancer. One being down to my experience of seeing people die from cancer, and also listening to the struggles that my mom faced when she was working as an oncology trainee in a pediatric oncology specialist hospital back in Sri Lanka. So my mom told me that the most frustrating and heartbreaking moments were when her pediatric patients died from opportunistic infections and malnourisement due to their weakened state as a result of the chemo and radiotherapy. And even after successful eradication or remission of cancer, they simply didn't have enough resources to cope with a large number of patients. The oncologist in her department, who had over time had naturally formed strong bonds with the deceased children who were under their care. And most of all, it was saddening to hear that these doctors were forced to suffer in silence, as any attempt to talk about their feelings was seen as a sign of weakness and may have had adverse repercussions for their medical career. So not surprisingly, this is also a common taboo in the medical profession, even in the UK. So this motivated me to look for life and ease the emotional burden for doctors as well. So the concept of venom-based drug was something that I came across when I was reading an article on new drug therapies for cancer. So venom contains a multitude of proteins and organic chemicals that have a wide range of potential medical applications. I learned more about this after watching David Attenborough's series on Planet Earth, where I learned there were two scientists working with many types of venom for cancer treatment at the Institute of Pharmacological Sciences in Melbourne, Australia. So I decided to give the Institute a call, and I was directed towards America, where I was put in contact with Professor Jim Olson. So Professor Jim Olson is a pediatric neuro-oncologist at the Seattle Children's Hospital and a full professor at the Fred Hutchinson Cancer Research Center and at the University of Washington School of Medicine. He has an impressive array of patents and awards and honors under his name, too many to count, and has mentored more than 30 graduate students and postdoctoral research fellows. Professor Olson's recent work was inspired by children with rare or incurable cancers, and it was based on his experience of one particular patient named Violet that led him and his team to create Project Violet, an organization which was dedicated to developing effective new therapeutics for pediatric cancers and to improve tumor resection during surgery. Professor Olson's tireless dedication to his work is fueled by generous donation from the public and his desire to improve the young patients' lives. We will have plenty of time for questions at the end of the webinar, and please remember to complete the survey after the event to claim your certificate of attendance. So without further ado, I will hand over to Professor Jim Olson. Over to you. Thank you.
Thank you very much, Nisal. I really appreciate the kind introduction. I'll begin sharing my screen now and switch it over to presentation, and we'll get started. So before I begin talking about some of the science we've done, I'd like to introduce you to my CEO, my Chief Executive Officer. After training in medicine and pediatrics and pharmacology and pediatric oncology, I had been out of high school for 17 years and still training before getting my first job in medicine. And unfortunately, when I went to interview at other places, some of the premier academic centers in the United States, the questions I got during my interview were, do you think you'll be able to get enough grants to support yourself within 3 to 5 years? Do you think you'll publish enough papers to make it from assistant professor to associate professor in 5 to 6 years? And people weren't really asking, how do you want the world to be different because you were in it? And so I was thinking about, even at this point, after completing all of that training, was thinking about leaving science and medicine, wondering, is this really the field that I thought I was training for? And at the time I was caring for this young boy, Hayden, and it was at his memorial service. Unfortunately, he passed away from his cancer. We kept him alive and very healthy and happy for 4 years. But when he passed away, I was at his memorial service, and his brother was giving the eulogy. His brother was only 8 years old, and no 8-year-old boy should have to give a eulogy for his little brother. But he was doing a beautiful job. He had the people who were congregated in the church laughing and crying and remembering Hayden in a beautiful way. And I was just sitting in the back of the church and thinking about this, and I decided that I would stay in medicine and stay in science, but this is the guy that I would report to, that I would kind of forego the usual brass rings of academic medicine, the grants, the manuscripts. If they came, that's great. But every decision we would make would be based on what we thought would be best for these kids. So please don't take my talk to be advice on how to formulate a career, because many of the decisions I make are exactly opposite of what it takes to be successful in academic medicine, but somehow or another it has worked out. So I'm going to present my talk today in 4 parts. The first is just to kind of give you the big picture of translational pediatric neuro-oncology and what are all the components to it, so that you'll understand how the venoms and drugs fit into that. And also I want to bring to your attention how we come up with these ideas. So I have Matthew's picture here today because every week when I go to clinic to take care of these kids, before I start seeing patients, I ask myself, what are we going to be doing today that I don't want to be doing in 20 years? So I'm going to give you just a few vignettes of ideas that came at the beginning of those clinic visits or after the clinic visits and how they influenced our work. And we'll talk about how we designed a technology for testing cancer drugs in humans instead of mice. And then I'll go into the venoms and the drugs from nature's blueprints. And finally, an offshoot of that came out of Project Violet, some really interesting new work that we've been doing on a really aggressive kind of cancer called acute myelogenous leukemia that occurs in children and adults. So for translational pediatric neuro-oncology, when I started my career in 2000, there were no mouse models of pediatric brain tumors. There were no ways to do preclinical trials to prioritize things. And when I went to the first national meeting of the Pediatric Brain Tumor Consortium, we were one of 6 elite academic centers that were brought to this consortium. The first argument I heard at the front of the room was between 2 of my physician scientist colleagues, and they were each arguing for a different drug to be brought forward for our first clinical trial. And one was suggesting that we bring his drug forward because it had been successful in a breast cancer trial. And the other was arguing that we should bring the drug that he was proponing forward because it was successful in a colon cancer trial. And I just realized that this is the best we have at the year 2000 from the best institutions. We need to do much better. And so we began, motivated by these kids and in collaboration with the surgeons who would collect tissues at the time of operation and transfer them to the lab to create resources. We began a 2-decade-long process where we took their samples that came in and we built a network where we could all share these with each other, with other scientists. And from that, we did genomics works on them, a lot of that done in the UK. And that led to the World Health Organization kind of revamping how we diagnose these tumors worldwide. And finally, our team has generated about 50 mouse models that each take the tissue from a pediatric patient at the time of surgery and graft them into the mice, study the genomics, study the genetics, and make them widely available to scientists throughout the world. Again, the idea here is in pediatrics, the number of patients is small enough that we can't do it on our own. We really need to collaborate. And by collaborating, we've been able to set examples that have been followed by those working on much more common kinds of cancers as well. The next tier on this process is, do you study drugs that were discovered elsewhere at Pfizer or Merck, and do you test them in your models and bring them forward? We've done a lot of that, and I'll tell you a little bit about some of that in the next slide. But also there's the discovered here, and that's, I think, where my heart lies, and why I was invited to give this talk is, can we understand the unique needs of pediatric cancer patients and discover new molecules that go into clinical trials for them? And then finally, there are the clinical trials. And this little boy over on the side, Hunter, has benefited from one of those clinical trials in that he had tumor paint and he was able to be up and playing within a day of his surgery, whereas usually kids are in the intensive care unit for most of a week and then unable to really get around very well after that. Altogether, the work from our lab has led to a dozen clinical trials, some national, some international. We've just learned this year, and this is very exciting since I spoke with Nisal and Puru, that we've had a 20% improvement in the overall survival at 5 years for kids with high-risk group 3 medulloblastoma based on a clinical trial that I've led over the past decade. And we also, from results that came out of our lab, improved survival for babies and toddlers to 84% for those kids who have localized medulloblastoma. And this is really important because when I started my training in Seattle, the survival rate was about 40%. So we've more than doubled it for these kids. And I appreciate the opportunity to be part of that. So the first concept that came to me when we were sitting before I saw patients is that I was going to be taking care of a little boy from Alaska, and I needed to prescribe a medication for his recurrent brain cancer, and he would be on a clinical trial, but had no idea if his cancer was already resistant to it. And so we created this technology in which we could inject multiple different agents, and these could be the peptides from Project Violet, these could be immune modulating agents, they could be chemotherapeutic agents, right into the tumors, and we could leave them in the patient and allow the drugs to have activity for a day or two before the surgeons removed them. And then we could see which drugs were working better than other drugs, which combinations were better, and why some of the cancer cells might be resistant to it. And the basis behind this is that 94% of all drugs that go into clinical trials fail. And I think the reason for that is that we rely on testing drugs in mice, but the tumor microenvironment really matters. It's not just the cancer cells, it's not just can you kill cancer cells in a dish, but how does the patient's own immune system interact with the cancer cells and such. And over here on the bottom right, you can actually see a T cell that has engaged with a cancer cell and is about to secrete granzyme into that cancer cell to kill it. These are things that you can't see in a laboratory. You certainly can't see in mouse models, but you can only see in human models. And so we created this technology in which we could put 8 different drugs into a patient's tumor while the tumor is in the patient and about a day or two before surgery. And then when the tumor is taken out, we cut it crosswise to those needle tracks, and we can see where each of the drugs were, and we can see whether or not the drug had a response. And here's an example of the 8 different drugs. You can see that some of these have really nice responses and some of them have almost no response at all. And then we can digitally determine which drugs or which cells are dying, which cells are not dying, which cells have biomarkers of response and not. And in this case, we relied on our friends, canine patients who had cancer. And we did a sarcoma study in which we injected 3 drugs that all killed cancer cells in the laboratory, but really only one of them worked well in patients. And indeed, the drugs that didn't work well in patients didn't work well with the needles, but the drug that worked well in patients did work. And we could go beyond that to see why is there a difference. And here you see that the drug that didn't work in patients or with the needles is failing to draw in T cells, whereas doxorubicin was drawing in T cells and also suppressing the checkpoints that would prevent the T cells from working. And you can see that here we can actually see the T cells injecting granzyme into the cancer cells and actively killing them. So this is now in national clinical trials with 5 pharmaceutical partners. We have treated dozens of patients, and we're beginning to learn how to understand which drugs work for which patients and to optimize it for that. We can also understand the barriers as to why some drugs work and some drugs don't work, and that helps the drug companies know which patients to enroll in their clinical trials. So moving on to the project that led to Project Violet and really brought us to where we are today with these protein therapeutics. One day when we were in clinic, we saw this patient, and this was a teenage girl who on first MRI you can see that there's a big abnormality over here. And for those of us who are used to this area of medicine, we knew that this looked like a pretty aggressive glioma, high-grade glioma, maybe a glioblastoma. And the short arrows kind of point to roughly where the cancer is, and the long arrows point to really critical, the primary motor strip of the brain, so that if the surgeons go too far and get into that primary motor strip, they would leave her permanently paralyzed potentially. And in the center, you see what the case looked like in the operating room. And if I gave each of you a scalpel and I said, can you remove the cancer without removing normal tissue, it'd be really hard to know what to cut and what to leave. And in this case, the surgeons worked for about 12 hours on this patient. And when we did the follow-up MRI, we see that there was a piece of cancer that was left behind. And the reason was that with the best tools that they had available, the surgeons thought that that was normal brain and they didn't want to harm this patient, so they left that behind. And importantly, they were using the best technology, so they were getting recordings and it looked as though that tissue had normal nerve recordings. So with every bit of their experience and every bit of technology that they had available, they still could not distinguish cancer from normal tissue. And this is really important because if we look back at all the papers that have been published for different kinds of cancer, we can see that the difference between those kids who have a complete surgical resection versus those that have bulky residual disease that you can see on the MRI, there's a huge difference in survival. Those kids with glioblastoma who had a complete resection had a 42% 5-year survival versus 0% for those kids that had residual disease. 80% versus 20%, 60% versus 10%, 80 versus 50, 90 versus 50, all the way down the list. You can see how important surgical resection is. So this day we decided that we were going to come up with a way to make cancer light up or glow so that surgeons could see the cancer and distinguish it from the normal brain around it. We turned to an unlikely ally, which is the Israeli death stalker scorpion. And here you see a picture of the scorpion itself. And on the right, you see the molecule that comes from its venom. In this case, it's called chlorotoxin. And it's one of thousands of mini proteins or peptides that are present in the venom. And what you see in blue here is a dye that we've chemically added to the venom. And I won't go through all the process unless we get questions in the question and answer section of why we came to focus on this particular peptide. And I can tell you that even after almost 20 years of working on this, we still don't know exactly why it distinguishes cancer from normal tissues. We've ruled a lot of things out, but we still don't have the actual answers of why it does. But I'm going to show you some of the work that we've done. First I'll skip over the mouse work, but I'll move to the canine patients and then to human patients. So we rely pretty heavily in the same way that we did with the CIVO technology that I was just showing you with the needles on larger animals that have cancer naturally. We think that it's a problem to test drugs or devices in mice because they really have a very different immune system than human patients do. Cancers don't arise naturally in most cases, whereas if you can get a product working well in canine patients, there's a much better chance that it will translate to human clinical trials. In this case, there was a dog that had breast cancer, and this is what it looked like to the surgeons. And again, if I were to ask you which of that is cancer and which of it is not cancer, it might be a little bit difficult to tell me. What we knew from physical exam and from a CT scan was that this area down here at 5 o'clock was cancer, but we really couldn't tell about the rest of it. When we turned on the laser that could allow tumor paint to light up, you can see that this area that we knew was cancer was indeed cancerous, but also that there were several other areas of cancer. And these were not little micrometastases, not a few cells scattered here and there, but they were big, bulky chunks of cancer that could potentially alter the outcome for this patient if they were removed. We moved from the canine patients to human patients, and these are some breast biopsies that were taken out. And you can see the difference between what they look like without tumor paint and what they look like when we turn on the laser, so we can see exactly where the cancer was. And this is important because surgeons can theoretically test during the operation whether or not there's any residual disease at their margins. And the pathologist can see where the tumor paint is closest to the margin and look there to see whether the surgeons need to keep going. We then moved on to brain cancer. And this is an adult patient with glioblastoma, one of the most aggressive forms of brain tumors. And you see up at the top here that the cancerous part of the brain tumor has already been removed. And then down below, you see the teal light shining through where there's cancer. And the reason that I show you this is because this cancer is not on the surface of the brain, it's below the surface, but we chose a wavelength of light that would shine through the normal brain so that surgeons could see exactly where the cancer is and remove that while doing the least amount of damage to the normal brain around it. An example of how this is important is shown by this 3-year-old girl from the eastern part of the state where I live in, Washington state, which it's about 200 miles from Seattle. And here you can see at the beginning of the case, the surgeons have to decide, this is looking down into the little girl's brain, and this is a recurrent cancer that came back only 5 weeks after her initial surgery, and they have to decide what to remove and what to leave behind. And it's really hard. There's a lot of different colors, there's a lot of different textures. When they turned on the laser, this little girl had gotten an injection of tumor paint the morning before surgery. They turned on the laser, and you can see that it's this area here that is representing cancer. That gives you a good starting point. So the surgeons then went on and did the surgery the way they normally would. And at this point, it was the end of the surgery, and the neurosurgeon said, with all of her clinical experience, this is where she would end the case. They believed they had all of the cancer removed. But in fact, when they turned the laser back on, there was a little, very faint glow of light from the bottom. In her surgical judgment, she removed it because she thought it could be cancer. And indeed, the pathology showed that it was cancer. And that was really important to get that last piece of cancer because the patient now is 3 years out from the surgery and hasn't had any radiation, hasn't had any chemotherapy, and cancer didn't come back. And so again, it shows the importance of surgical removal of cancer. So this is where we stand today. Now we've treated over 150 patients. We haven't had any dose-limiting toxicity. We found that tumor paint illuminates most types of pediatric and adult brain tumors and breast cancer. It has the potential to help as many as 2.5 million patients per year. And we're in the final trial that could lead to FDA registration. All of the clinical trials are being led by Blaze Bioscience, which spun out of the Fred Hutch Cancer Center where I work. And they're in the process of bringing this to conclusion to the point where we might be able to market it and expand its indications for other kinds of cancers as well. We've kept the focus on kids for all this time because they were the ones that inspired us, and they were the ones that really moved it along. The kids that I take care of are always on my mind every minute of the day. And sometimes, you know, the most creative thinking that we do doesn't come from Zoom meetings or PowerPoint presentations or even lab meetings. Sometimes my best ideas come when I'm out exercising, swimming or running or doing cycling. And in this particular case, the reason I put this picture up is because we were traveling through France one year, and it was after we had discovered tumor paint and when it was on its way into clinical trials. And I noticed this beautiful field of sunflowers. And if you look closely, you see that all the sunflowers are completely intact. Now, these are bright yellow flowers. They're packed with nutrition. And I was wondering, why are the bugs not eating these flowers for breakfast? That's what I would do if I was a bug, right? But the fact is that when I looked into it, sunflowers make their own kind of drug that makes the trypsin that's released by insects useless. It blocks the proteins that would break down the sunflowers and allow them to be eaten as food by the insects. And it turns out that the structure of the drugs that these sunflowers are making is very similar to the structure that the scorpions make in their toxins. And, you know, as with most good ideas, I was far from the first to kind of start making these connections. It turns out that other people have been working on this for about 15, 20 years, understanding that there are these really stable mini proteins in nature that could potentially be used as drugs for humans. The thing that I like about these, this is kind of a depiction of these drugs. They have a disulfide bridge here, a sulfide bridge here, and a third disulfide bridge there that ties it into a knot. These little mini proteins are 20 to 60 amino acids in length. They usually have 3 or 4 disulfide bridges that tie them in this nice tight knot. Because they're such a tight knot, they're protease resistant. And because they're protease resistant, they don't get broken into little fragments that can be presented to the immune system. For that reason, they have very low immunogenicity and they make good protein drugs. they also have antibody-like affinity. They're big enough that we can tune them to bind to their targets with picomolar affinity in many cases, and sometimes nanomolar affinity. And some of these molecules penetrate into areas of the body that most protein drugs would not get into, like across the blood-brain barrier, and in some rare cases, even into cells. Now, these drugs that we're talking about are very different than most of the drugs that are approved by the Food and Drug Administration in the US or the equivalent agencies elsewhere. Antibody therapeutics are huge, and these are depicted over here on the right. And most small molecules, like this chemotherapy agent Gleevec, is a small molecule shown here on the left. And the molecules we're talking about are kind of mid-size in between. And that creates a lot of opportunity to address diseases that can't be addressed by traditional drugs. The way that others went about discovering these were pretty challenging. They would tape a scorpion to the desk in their laboratory and use electrodes to milk the tail and collect the venom that came out, and then do biochemical analyses to identify each of these. And then sometimes they would try to synthesize these on a peptide synthesizer, but getting them to fold properly was really a challenge. So I give the scientists that were working in this field for decades a lot of credit, because together as a community they identified about 2,000 of these little mini protein drugs from scorpions and other venomous animals and plants. But the whole idea for Project Violet was, I thought that we could do better than that. I thought that we could identify tens of thousands of these drugs from nature and create a whole system for robotically producing them and testing them. And I was inspired to do this by this little girl, Violet, who I took care of. She was diagnosed when she was 10 years old, and she passed away when she was 11 years old. And she was just a ray of sunshine at the hospital. She brought so much joy into her family's life, into the nurse's life, into everybody around her. And she also had this incredibly generous spirit. You could tell she'd grown up in nature. She was always out in the garden with her dog. She was always out in the woods in the Olympic Peninsula near Seattle. And so I just felt that this proteins that came from nature were so closely linked with Violet. And she had also done one of the most generous things I had seen, which is when she learned that she was going to pass away from her cancer, she asked whether or not she could donate her brain to science to help kids in the future, so we could better understand her disease and try to change it from a disease that had basically 100% fatality. All of the kids that I've cared for, all of the kids that my friends have cared for have passed away from this disease. So it's, my career goal is to be able to walk into a patient's room whose child has this disease and say, we have a genuine hope for you, that there's this therapy that we've created or that our colleagues have created that we think will overcome this disease. And I like to show this particular picture because in the middle of every violet, everybody thinks of a violet flower as being purple, but in the center of each one is this bright splash of orange. And that just reminds me of Violet, the patient, every time I see it. So we began this program and we asked people to philanthropically chip in to help us create these drug candidates. People could adopt a drug for $100. And that was enough to allow us to make the first candidate. As opposed to the 2,000 drugs that had been discovered over the previous 2 to 3 decades, our team discovered 80,000 more candidates, and we did that over the course of less than a week. We wrote a Python program that went through all the genomic databases and identified all the candidates from every species. And you can see that these come from all clades of life and that they're different lengths, and that there's a lot of information that we could gather even from just studying these computationally. But then we began producing them, and we began focusing on those that would produce the most amount of drug when we produced them in human embryonic kidney cells, and also the ones that were most protease resistant. We thought that these would make the best drugs for human patients. And I'm not going to go through a lot of the different drug candidates that we found. We've published a lot of this that is available in the literature for you to look at, but I'll give you some examples. The one that I'm showing you here is a drug that we have designed to fit into a cleft in the protein called TEAD. And TEAD and its partner YAP are proteins that are normally expressed in the embryo in development, and they cause organs to grow rapidly. They're supposed to be kind of shut off after we're born in most tissues, but cancers have a way of co-opting these neurodevelopmental pathways to help the cancer grow. And in this case, when YAP and TEAD come together in cancer cells, they spur growth of the cancer cells, and in some case, dissemination of the cancer cells. And so we were able to, starting from these drugs in nature as blueprints, and then morphing them and substituting every amino acid with every other possible amino acid using really advanced computational approaches, we could design molecules that would fit right down into the cleft of TEAD and prevent YAP from binding to it. And in doing so, we could prevent the cancer cells from proliferating and growing. We have an ongoing program in which we're working for ways to make these penetrate into cells better, because that's where this interaction takes place. We've also thought about our patients. Remember the patient that I showed you, the early picture and the later picture of he and I, Max. He's a boy who was diagnosed with a medulloblastoma when he was 8 years old, and we treated him with radiation to his whole brain and spine. We gave him chemotherapy. He survived a cancer that was uniformly fatal when I was a baby. And he went on to college, where he graduated near the top in his class with nearly straight A's. And that's all the more astonishing because the radiation that we used on his brain makes it very difficult for him to learn new facts. And so he had to work probably 30, 40 times harder than any other student in his class to get an A, because he learns something and he forgets it almost immediately, and he has to just keep working to solidify those facts. So we're working on a molecule right now that would cross the blood-brain barrier, and it would shut down the inflammation that occurs following radiation therapy to the brain, so that there would be less damage in an ongoing fashion to these kids who are irradiated as children, but then need to grow up and try to hold a job, try to go to college, try to be in a relationship. And these things are all very challenging for patients who have gone through the therapeutics that we give them as part of their care. So, you know, really, we're inspired by each of these little guys. This guy, Kyle, he and I shared a birthday, and he was naturally the most athletic human being I'd ever met. I took care of him when he was 7 years old. He had a brainstem glioma, the same kind of cancer that Violet had. He had already lost vision in one eye. He had lost a lot of his ability to speak. And yet he competed in soccer and in ski racing while we were treating him, and while he had very impaired balance from his tumor. During that summer, he scored more soccer goals than all of his teammates put together. And during that winter, he won every ski race that he did up at Mount Baker. And it just kind of goes to show the range of capabilities that humans have, and why it's so heartbreaking when these kids have these diseases that really kind of come out of nowhere. And we have to learn to work with their families to be able to share hope. And even in cases like his, where we know from history that there's very little hope for survival. And so what we hope for is that the end of life is as good as it can be. And even right up until days before Kyle passed away, family friends brought him up to the top of Mount Baker on a snowmobile, and he was unable to walk at that point, but they got him into skis, and he skied all the way down the mountain. And it just kind of reveals the human spirit and what you are capable of doing when nobody thinks that you could do that. And in many cases, that applies to the work that we do in the laboratory as well. An academic lab is not the place where new drugs come out of that help cancer patients very often. Usually it's biotech companies and pharmaceutical companies. And if it is an academic lab, maybe it's one that comes out of a lab out of the course of your entire career. And we're in the process now of advancing 4 or 5 drugs already into human clinical trials. And so these kids just keep inspiring us. There's no reason that there should be these kind of limitations. And again, if you kind of ignore the trappings of academia and really focus on what's best for these kids, you can make breakthroughs where it might not have been considered possible in the past. So we've also been fueled by our patient families. This is the Run of Hope, which is our brain tumor community. We get together every September, and all the families come down to Seward Park, which is near my home, and they get pledges and raise money for the races they do. And all this comes into Project Violet, and it fuels new projects that we don't yet have grants for and that we have ideas for. It's just been an amazing community. And we even extend these beyond brain tumors and thinking beyond that to things like acute myelogenous leukemia. So I've been a pediatric oncologist for over 25 years now. And one of the types of patients that has been very challenging for me emotionally are these infants and toddlers and children with acute myelogenous leukemia. This is a kind of leukemia that is very aggressive, and it needs multi-agent chemotherapy, and in many cases, a bone marrow transplant. The therapy that we use is so toxic, as you heard at the beginning, that some of the kids, if we sent them home for the weekend, would die from infections due to their weakened immune system. And so these kids have to stay in the hospital for 100 days following diagnosis while they go through the chemotherapy. They call it AML jail. It has a short survival. It's only 24% of these patients survive for 5 years. The therapies we use are extremely toxic. Bone marrow transplant is very common. And so I really felt that we needed to try to do something for these kids. One of my colleagues, Sohail Mashinchi, and a broad group of collaborators of his through the Children's Oncology Group unexpectedly discovered that a protein called mesothelin was present on the surface of about a third of pediatric AML cases. And so we wondered whether or not we could target pediatric AML by creating a bispecific antibody, again, using blueprints from nature to go after this disease. And so those of you who are familiar with kind of basic immunology will see that this is a pretty standard antibody, and it targets mesothelin. But what we've engineered differently is we've hung some additional molecules that would bind to CD3 on T cells and connect the T cells to the cancer cells and instruct the T cells to kill the cancer cells. And we made this and tested it in a patient model where we took the cancer cells from the patient. We quantified how many mesothelin molecules were on the surface, found that this was pretty typical for other patients, and we implanted this into mice, and then we treated with nothing at all, or chemotherapy, the kind of standard chemotherapy that would be used to treat this, or T cells alone, or our targeting molecule plus T cells. And you see that all of the first 3 arms, the mice all died by about day 35 or day 36. But by day 60, 100% of the mice that had been treated with just our bispecific antibody alone were alive. And so this is, survival in the absence of chemotherapy and in the absence of radiation therapy. This is where we want to go. And importantly, when we looked at these patients, we saw that when we looked at T cells, that the T cells were proliferating and very present in the marrow, but the AML cells were completely absent. So in these mice that survived up to day 60, there was no evidence with a very sensitive assay of any cancer being present. And so we wondered, is this just typical of this model, or could this be true of other patients as well? And so we tested it in another patient, and in this patient's cancer, there were even fewer mesothelin molecules on the surface. And we again treated with nothing, T cells alone, the bispecific antibody alone, or the combination of the bispecific antibody and T cells. And all of the control arms, the mice died. This is a different model, different aggressiveness. They all died by about 126 days, whereas 80% of the mice were alive and disease-free by day 520 with our molecule. So here again, this is a molecule that's now moving toward human clinical trials. We spun out another company called Link Immunotherapeutics that's advancing this therapy for patients, both pediatric and adult, that have mesothelin on the surface of their AML. You can imagine that if the best chemotherapy is not really extending survival very much in these 2 models, but our bispecific antibody is, it would be wonderful to someday completely replace chemotherapy or bone marrow transplant for these patients. So I guess I've already said all of this. And so I'll move on to thanking my team. Here's a picture of us pre-pandemic when we didn't have to wear masks and could stand next to each other. The team has evolved. I'd also like to thank my colleagues at Presage Bioscience, that the needle array that I showed you, the CIVO work at the beginning, Blaze Bioscience, where the tumor paint work is done, and the team from there that shared the pictures from the operations in human patients. The Children's Oncology Group, where we collaborated to build these huge tissue banks, and we collaborate with colleagues all over the world, many in Europe. And then finally, the National Institutes of Health and Project Violet funding the work. So I'll wrap up there and take any questions that you might have.
Thank you very much, Professor Olson. We're checking for, that was brilliant, really moving and really inspiring. I'm just checking on the question chat for any questions. And oh yeah, if you want to ask your question live, then please mention it so we can add you to the panel. But does anyone have any questions to ask? Anyone at all?
Nisal, is it, if it's okay, could I start off the Q&A with a question?
Sure, yes.
Yeah, so I'll just reiterate what Nisal was saying. Fantastic talk. Thank you so much for giving up your time to come and speak to us today. There was one thing which you mentioned in your slide, and do correct me if I've got this wrong, the use of tumor paint for some of the brain cancers which the surgeons resected, you said didn't require chemo or radiotherapy follow-up. Do you think if that tumor paint model was sort of widely rolled out, would it be a more sensible option to just give that chemotherapy and radiotherapy afterwards, just to be on the safe side, to make sure that if there are any remaining parts of tumor have been completely eradicated? Or have the results which you've identified shown that you really just don't need to use chemo and radiotherapy after surgical resection using the tumor paint?
I'm glad you brought that up, because that's a really important point. You really need to understand the biology of each type of cancer. And in that particular cancer, it's a tumor that we generally don't treat with radiation or chemotherapy. And if it does come back, if you get a complete surgical resection, you then tend to not treat it with radiation and chemotherapy. For the other kinds of cancer that require radiation and chemotherapy, we wouldn't consider tumor paint driven surgery to be a substitute for that. We would always use radiation chemotherapy afterwards, because we know that there are microscopic disease cells that are embedded in the brain that we can't see with tumor paint. And the last thing we'd want to do is have a patient die who could have survived if we'd been treating them with standard practice. So the places where I see us moving away from chemotherapy and radiation is more with these other proteins that we engineer to locally get the immune cells to kill the cancer cells. And in some cases, like the AML example that I gave you, we would inject these into the patient, into their bloodstream, and it would go through the whole body and connect the immune cells to the cancer cells and cause the immune cells to kill the cancer cells. But in other cases, one of the students in the lab has come up with a way that a neurosurgeon, at the end of surgery, when they know that they've taken everything that they can, but think that there might be microscopic disease around it, could inject some of these molecules into the brain surrounding the surgical cavity so that the immune cells could mop up or remove any of the remaining microscopic disease that's left behind. And we've even been thinking about ways to make that kind of a time release mechanism so that the immune therapy would keep occurring over the course of a month or longer. Because one thing that's really important about kids with brain tumors is you can't keep going back in every month and, doing additional surgery. So you really want, you need to be very creative about, you don't want to design a whole drug that lasts for 2 or 3 hours and then goes away and stops working. You really want to create something that works much longer.
Thank you very much.
There are two more questions. One is asking, are there tumors that the tumor paint doesn't work on?
We don't know that yet. We have tested many types of tumors in the laboratory in mouse models, and most of those have lit up beautifully. Skin cancer, prostate cancer, breast cancer, colon cancer, brain tumors. We have done human clinical trials with breast cancer, 3 types of skin cancer, and many kinds of brain cancer. It's lit up all of those. In the laboratory, the only model that really surprised us was pancreatic cancer, where tumor paint lit up the extracellular matrix around the cancer cells, but didn't light up the cancer cells. And we actually think that the negative charge on that extracellular matrix, the hyaluronic acid, kind of mopped up and sequestered the tumor paint so that there was not enough of it available to get to the cancer cells. But I think the sequence of events would be that we'll try to get approval from the FDA if they believe the data is strong enough for pediatric brain tumors. Then we would expand that potentially to adult brain tumors, and then see if we can get it to work for breast cancer or sarcomas and expand it out for therapeutics that way. But then the other question is, if it shows itself to be safe for all these cancer surgeries, could we then use it for cancer detection to detect cancers really early before they become a problem? So for example, patients that are at risk for getting head and neck cancer, could we take a look inside their mouth and throat and see if there's any pre-cancerous lesions? For patients with potential skin cancer, could they take a dose of tumor paint and then just get a scan by their dermatologist to see if there's any lesions that are turning into cancer? Because right now the sensitivity and specificity for dermatologists doing this by sight is really not very good at all. It's quite poor.
Great. Another question is that would there be a possibility of using brain organoids to test potential drugs rather than using mouse models?
Oh, absolutely. A lot of my colleagues are doing that, and we're building programs like that all around the world. They are better than two-dimensional tissue culture, and particularly if you can grow them with immune cells present, that's helpful. It doesn't replace the rest of the tumor microenvironment, and it doesn't replace the rest of the body. So there is no perfect model. All you have to do is kind of combine different pieces of data and know what the strengths and weaknesses of each are. The organoids are helpful because you have good cell-cell interactions. You have some areas that get lots of oxygen and some areas that get very little oxygen, so that replicates what's going on in real cancers. In some cases, you can grow some immune cells in them, but it's not really clear that that mimics what's going on in human patients. So there are still some very big gaps between any models that we use and human cancer care.
And there are 2 more questions. Is tumor paint used worldwide, or is it still at the initial stages?
The very first clinical trial was run in Australia, and all the rest have been run in the United States. At the current time, the only trial that's open is the registration trial for pediatric brain tumors. We're hoping to expand that dramatically in the coming years. We'd love to have it be available worldwide.
And how long do you think it would take with some of these innovations approaches to become more common in practice?
The duration of time is something that's, you have to be very calm about this, because we first published the results on tumor paint in 2005, and now it's 2021. And all of these steps take time, and the regulatory processes take time. The clinical trials take time, manufacturing takes time. We have seen over this past year with COVID vaccines that those timelines can be compressed dramatically when the benefits outweigh the risks. And I don't know what lessons will be learned from that and applied to drug development. We've also seen an acceleration of the timelines for CAR T-cell therapies. Some of those therapies have gone from ideas all the way into patients in the course of 2 to 3 years, as opposed to 15 years for drug development. And so I hope that we can learn from all of this, and particularly when you recognize, cancer as an enemy, it's a multifaceted approach. I always liken it to that cancer is playing chess while oncologists are playing checkers. We make one move at a time, advancing one drug that hits one target through 15 to 20 years of clinical trials. And within each given patient, the cancer is evolving and coming up with ways to circumvent that and many other drugs you throw at it. And so I really hope that we can come up with ways where we could combine multiple molecules that hit multiple targets simultaneously. But there's still a very big reluctance to do that on many levels.
Okay, and someone else was asking, for the drug candidate to reduce inflammation post-radio or chemotherapy, do you have any early indications of how effective or function preserving that could be?
We don't yet. Right now it's still at the stage of, we have the hypothesis, we know how the immune cells in the brain get turned on, and we have a ion channel target that if we shut it off, we think that those cells will be less inflammatory. We've created drug candidates that hit that target with very low concentration, and a small amount of that drug gets across the blood-brain barrier, but what we're doing right now is making variations to get across the blood-brain barrier better. So we anticipate that next year we'll be in the position to test the effects of that candidate on mouse brains that have been irradiated and have chronic inflammation. And if we see a positive signal there, then we would begin moving to larger animals and eventually to human clinical trials. So we have a ways to go on that project.
And the final question is there a way in which the tumor paint can be detected by imaging rather than the fluorescence dye?
Tumor paint is light-based molecule, so in order for it to give us a signal back, we have to hit it with a laser beam, and then it shines light at a different wavelength that can be detected by a CCD camera that accumulates the images and gives you the kind of signals that we saw previously. Now, if we made a radioactive version of that, it could potentially be used for PET scanning and seeing deep tissues in the patient as a diagnostic. We don't know whether that would be any better than MRI, because the problem with PET scans is that the spatial resolution is not very good. So with MRI, we can detect sub-millimeter tumors, and we're not sure that you'd see much better than that with a PET scan. So at this point, we're focusing on exactly what we're doing, the surgical-based use of tumor paint, and then eventually early detection of cancers that are at the surface, like oral cancers, esophageal cancer, colon cancer, skin cancer. But we don't currently have plans for how we'd use this as a diagnostic for deeper types of other cancers.
Thank you so much. Izzy, do you want to say something on behalf of PaedSoc?
Hi there, yeah, so my name's Izzy, I'm on the Pediatric Society here, and I just wanted to say a massive thank you for your talk this evening. It's been really great to hear about your research and how this impacts on children and their families, and how the children you meet have encouraged your work and research. So just a huge thank you from us here at BSMS Pediatric Society, and it's been so interesting and informative.
Oh, you're welcome. I would say we're just getting started. We have a lot of big plans ahead. And if there are people in your program that are interested in the work that we're doing and have the laboratory-based training, they should reach out to me, and we can, we are always accepting postdocs and other fellows to do work in the lab, and have quite an international community.
Puru, I think you said you have one more question to ask.
Yes, it relates. It relates more to something which Professor Olson, you were talking to Nisal and I about back in March when we initially met, and that was sort of another thought-provoking thing which you said about how you share your research around with other groups when you think you've sort of brought it to a stage and someone else should take it on, and then you can take on another project. Could you sort of elaborate on that? Because I think for our audience that may sound slightly strange, but also enlightening as well in terms of how you should approach research.
Yeah, so that's a really good point there. That's one of the examples I said at the beginning of my talk, that the way that I've built my career is not necessarily the way that I would recommend other people to build their careers. But in some cases, I think having a North Star, having a patient that you think about or a goal that you're going after, and being unafraid to fail is a really important of actually being successful. And so I don't regret those things. And for some people, it might be the right thing to do. And so what you're talking about here is our lab, once other labs are able to do what we do, we stop doing it and we let them do it and send them ideas, encouragement, resources. An example are the patient-derived tumor models in mice. We've made about 50 of them, and now other labs make them well, so we no longer make them. And this is not the best way to get your next grant and your next grant and your next grant, because usually in the grant systems, both in the UK and in the United States, your prior work, you build on that, and that's how you get your next grant. But for our team, we're constantly evolving, and what we just mastered, we stop working on, and we work on something that's really new and innovative. And so, that's why, first of all, I think the philanthropy has been so important, because those dollars are not tied to specific projects, and they let us really go after the most aggressive, creative ideas that we have. And so that is a necessary part of trying to be creative. But also, I just think that, life is short, and we do so much better when we cooperate than when we compete. So basically, I tell the people in my lab that they can discuss our work with anybody for any reason without hesitation, and that what we gain from that will be so much greater than the risk of losing something competitively. And after all, we're all doing this for the same reason. We're trying to help these kids or adults with cancer or other diseases improve. And so why not work as one team?
Just to follow up again, because the position which a lot of my fellow students in our second year are in at the moment, we're doing our immunology module, and we're looking at a couple of various different therapies for things like melanoma in particular. And one aspect which we've looked at in our reading is sort of combining a lot of innovative new therapies which they've come up with, especially immune checkpoint inhibitors. So I think for especially advanced stage melanoma, combining nivolumab and ipilimumab seems to have been quite effective. Do you think this notion of combining therapies is going to be the way forward because of how heterogeneous cancers can be and how many different targets we're going towards in your analogy of trying to win that game of checkers per se, to try and hit multiple targets at once?
I absolutely think that combination therapy is the right way to go. I also think that the way that we're getting there currently is the exact wrong way to go. And so when you think about it with nivolumab and pembro, in both of those cases, the drug companies sponsored hundreds of clinical trials, and it was like throwing noodles at the wall to see what would stick. There were thousands, tens of thousands of patients that went through clinical trials with really no data to suggest that this would work. And in all those cases when it didn't work, they were not getting another therapy that might have been more effective. And when you think about the money that was thrown at those clinical trials, billions and billions of dollars. And the example that you give is one of the very few where a combination really was quite successful. And there are hundreds of other clinical trials where the combination showed no benefit. So where I think we need to go is to understand early on the biology of the immune system, and to, from the beginning, create drugs that work combinatorially to be more effective and less toxic, and bring those drugs forward together rather than waiting for one of them to get approved and then seeing if the other approved drugs happen to combine well with it. But I will tell you that the barriers to doing that are very high. The team that came up with the bispecific antibody for AML that I showed you had originally planned to use 2 antibodies that would be used in concert to bind on 2 different targets on cancer cells and 2 different targets on T cells, therefore creating a positive loop that would properly tell the T cells and properly co-stimulate them so that they would proliferate and that they would be ready for the next cancer cell. And in speaking to over 100 venture groups, most of those groups were very reluctant to invest in a molecule, in a pair of molecules that would have a higher regulatory hurdle at the FDA and would have higher manufacturing costs. And so we have to get past those mindsets that are barriers to developing drugs that are combinatorial from the beginning. And that's one of the things that I hope we'll see change over the next 10 years.
How would you sort of go about the process of changing that? Because it almost seems above the level of what a researcher or a scientist would do. It's almost like trying to make the system work towards what you're trying to do. So is there a way which you can see of trying to enact change, or is it something which you've sort of just got to sit back and hope the system does change to facilitate that?
There's 2 ways to effectively cause change. One of those is to get a drug combination approved that is extremely effective because it's a combination, where either drug on its own has very little activity, but the 2 drugs together have profound activity. And once you get one of those approved and it proves to be a blockbuster, then the gates open and it becomes easier to do that. And so what you need to do there is to gain the trust and get the financial resources to bring your best idea forward and show the world that this is the right way to do it. And that's my preferred way to do it. The other way is that the FDA is really good about listening to the scientific community, and they will set up workshops where we can get together and talk about things that we see on the horizon, things that they need to evolve for. And so I think that they are actually ahead of the funders in preparing for combination therapies. And I think that when a good idea comes to them, I think they will handle it beautifully. But I think it's really getting past that kind of psychological barrier that people say, well, this isn't typically done, so I'm not going to be the first to do it. And that's such a big part of human nature that you need to find that group of funders that recognize that you have a very talented team and these are really solid ideas, and they're willing to, it used to be called venture capital for a reason, because you're stepping out there into not knowing for sure that it's going to work. And I wish there was a little bit more adventure in venture capital.
Thank you so much. I will hand over to Nisal.
Great. Does anyone else have any more questions? Nothing in the chat box, so I take that as a no. So to conclude, ladies and gentlemen, on the behalf of BSMS OHP Society and PaedSoc, I would like to extend my formal thanks and gratitude to our keynote speaker, Professor Jim Olson, for the thoroughly engaging and thought-provoking webinar this evening. Professor Olson, I just have to say that you have an outstanding reputation on a global stage as a researcher, clinician, and educator. The empathy that you displayed during your presentation and reflection is truly inspiring. You have established an excellent example of how the scientists, researchers, and doctors of the future should behave by placing their needs and wishes of their patients at the center of everything they do. Thank you so much for giving up your time today to speak to our society. It's really appreciated. And if you ever happen to visit the UK sometime, please come down to Brighton when it's warm and sunny. At the moment, it's raining and dull. In the summer, hopefully, when it's sunny. Lastly, I would like to thank all the students that attended and the students who were involved in setting this up this webinar, including Farazi, Virk, who lies between OHP and PaedSoc. And I would also like to thank clinicians across the Sussex County who attended this evening. So that concludes our webinar series for this year. And also please do tune in on the 10th of May when we launch the OHP Journal Club under the wise guidance